So without further ado, I'm going to introduce our guest speaker this evening, who is Dr. Liz O'Riordan, who is a breast surgeon and somebody who's also had breast cancer. She's an author, podcast host, has got her own Instagram, YouTube and Twitter accounts. So thanks ever so much for joining us again, Liz. And we'll get started with the questions. I think we've got probably so much to pack into this evening. And hopefully we'll get through most of it. But as I said at the beginning, really, we're going to try and answer as many questions this evening around breast cancer surgery. And I think we'll touch on breast reconstruction, but that is a whole topic in itself. So I think really to get us started, Liz, it would be really helpful to talk through the types of surgery that people might be offered when they have a breast cancer diagnosis.
Great. So the main treatment of every breast cancer is surgery to remove it. And that means removing the cancer with a rim of healthy breast tissue around it. And I kind of describe it like a peanut M&M. You've got the peanut in the middle with a chocolate coating. The operation we do depends on the size of your cancer compared to the size of your breast. You can have a 5 centimeter cancer in a big J-cup breast, and we can easily remove that and leave the breast behind. But if that 5 centimeter cancer is in an A-cup breast, then there's not a lot of room left. And as a rough guide, your surgeon can remove up to a fifth, that's 20% of your breast tissue, and use clever techniques to reshape and redrape it and leave the breast looking approximately the same size. If we have to remove more than about a fifth of your breast, then just removing the cancer will not give you a good cosmetic appearance. The two main types of surgery are a lumpectomy, which is also called a wide local excision, or a mastectomy. Lumpectomy just means removing the cancer with a rim of normal tissue. Your surgeon aims to take a centimetre of tissue all the way around the cancer. That gets looked under the microscope to make sure the margins are clear. Now, a lot of surgeons now are trained in, it's called special plastic surgery techniques. So we can hide scars around the nipple and we can tunnel up so the scars are invisible. We can put them at the bottom of the breast and out the side. And we can redrape the skin and move tissue around so you don't have a divot in the breast. Another form of doing a lumpectomy is actually to remove a lot of tissue and do it like a breast reduction. So we can take away up to a half of your breast tissue with a cancer, either the top bit or the bottom bit, and reshape that breast and do the other side to match. So you get a breast reduction, but it means we can avoid doing a mastectomy. A mastectomy is done when there is too much breast tissue to be removed, and it would give a really bad result cosmetically. Or if you have inflammatory breast cancer when the breast skin is involved. And what that means in its simplest sense is just removing all the breast tissue and the breast skin. We cut around the breast area, and then what we do is we close the skin like that, leaving a scar that could be flat, it could be J-shaped, it could be curved. And that's a simple mastectomy. If you want to have a reconstruction, then we leave the skin or the nipple and skin behind and fill that space with either an implant or your fat or your muscle.
Great, that's really helpful, Liz. And just going back to the technique where you were saying that you can remove the lump, but a lot of the breast tissue and redo that. Is that known as, has that got a term that's used?
It's called oncoplastic, which means onco for oncology, removing the cancer, and then using plastic surgical techniques. And most surgeons in the UK are trained in these techniques, and it's just automatic. Think of it like taking a slice of cake and having to make the cake look like you haven't taken anything away. And we do that by moving things around. And that's where we often say, don't do any active sport for a good 3 or 4 weeks, because there's tissues inside your breast that are holding everything together whilst it knits.
Great. And the other question that comes up a lot is around margins. And lots of people will say that they might have to go back and have a margin re-excised. And why would that happen?
Yeah, I'm going to try and explain this really simply. I want you to imagine an orange. You've got the fruit in the middle and you've got the pith around the outside. What I want is the cancer with a good 1 millimeter clear margin of normal tissue all the way around the cancer. Now, a millimeter doesn't sound like a lot, but there's about 10,000 cells in that millimeter of tissue. What the surgeons do is put their finger over the lump, and my finger's about 1 centimeter in size. So I'm assuming that if I do that, there'll be 1 millimeter left. The problem is that there are breast cancer cells that are invisible to the naked eye, and we know that if your cancer is invasive, those cells can potentially start to move through the breast tissue and spread around. And there may be breast cells in that rim of healthy tissue, and I only know they're there when it's looked at under the microscope. And that's when it's about 10 to 20% of women where the pathologist says, actually, there are some cells still at that edge. And we do this to reduce the risk of your cancer coming back at the breast. And that's when you may hear, we need to take another little rim of normal breast tissue. And sadly, some women need to have 2 or 3 operations and end up having a mastectomy just because that cancer is bigger than we thought. But we can't see the cells on a scan. We can't feel them inside the breast. It's just one of the peculiarities of breast cancer.
And that can be a really difficult dilemma. We often speak to ladies where they'll sort of say it was close to the margin, and they'll say, well, why do I need to go back? Because there's a possibility you could go back and there's nothing further to take.
Yeah, exactly.
And particularly when that's going from a lumpectomy to a mastectomy.
So these are done on the results of trials trying to work out how much breast tissue to take. Now, some people are happy with margin clear at the ink, so that there's no room of normal tissue, and we are doing less and less and less as our radiotherapy techniques, the other drugs we give you, are getting better. It used to be at like a centimetre clear margin. Now we want 1 millimetre. And again, as you said, there may be no cells in that bit of tissue, but there's no way of knowing, and it's a really hard thing to decide. What I should say is there are 6 margins. The margins the surgeon is concerned about, we call it superior and posterior, up and down, medial and lateral, left and right. But there's also the margin at the back of the breast and underneath the skin. The back of the breast is the posterior margin. And what your breast surgeon does is take a core of tissue all the way down to your chest muscle. So if it's right at the back of the breast and that posterior margin is positive, there's no more tissue to take. You might end up having radiotherapy to your chest wall just to kill any cells there. The anterior margin means that the breast cancer is coming right up to the surface of the skin. But there's no more breast tissue to take. There's nothing else we do for that. We assume it's all been taken away. But it's really hard to get your head around. And as a surgeon, you think, oh, do I go back? Do I not? Will radiotherapy do it? It's based on the trials that we have, and we are changing the margins that are acceptable as time goes on.
And I wonder, another question is people will ask when they have reconstruction and it's a skin-sparing mastectomy, what the decision making is around keeping the nipple or not keeping the nipple?
Great question. So your nipple, I need, hold on, I've got a biscuit. I'm going to assume my biscuit is my nipple. I'm in a hotel room, everybody. Hi. My biscuit is my nipple. My nipple gets its blood supply from blood vessels coming in from around the edges. Okay, that's how it gets its blood supply. And also most of the blood is coming up through the breast tissue. If I remove the breast tissue, my poor nipple is only relying on the blood vessels coming in through the skin. It's lost 90% of its blood supply. If you have a relatively small breast, like a C or a D cup that's not very droopy, the chances are the nipple will survive because you do a cut underneath here. So all these blood vessels go. The nipple is now depending on blood just coming in from the top half. Now, it's fine if you're shaped like me. That nipple is going to survive. They often look a bit blue, and you can often, the stub falls off. I lost my nipple itself. The areola survived. But if I've got a really big breast and my nipple's down here, that's a really, really, really long way for the blood vessels to get to my nipple, and the nipple dies. It doesn't survive. So it's basically, if you can hold a pen underneath your breast, then it's too big to have a nipple-sparing mastectomy. What we can then do is tattoo them on or do nipple reconstructions at a later date. But it's all based on blood supply. And that's the same with a mastectomy. The skin survives if it has a good blood supply. And that's where it's the hardest operation we do as a breast surgeon, to keep that skin healthy.
And would it be to do as well with the position of the tumour? If the tumour was quite close to the nipple, would that also be a reason why not?
One time we wouldn't do it is if the tumour is behind the nipple. Then we would have to take that skin over it. So you can't have that done. Thank you for reminding me about that.
Great. And just going back to how sort of surgeons decide around sort of whether or not you're offered a mastectomy, a lumpectomy, you might be offered both. What's the sort of decision making around? I know you've sort of touched on it, and also touching on the sort of study that was mentioned last week that some people may be aware of.
So The first point of view of deciding what surgery you have is that we look at the size of your cancer compared to the size of your breast. We look at the mammograms and scans. Can we get around it? And that will say, your breast is big enough for me to remove it and give you a good result, or I've got to take too much tissue, it will look awful. And we used to do this. We just used to cut the breast cancer away, and women would end up with bird beak breasts where they kind of fold in and just looked awful. We don't do that now. But the surgery you have depends on the quality of your skin. If you've been sunbathing and smoking for years and years and years, your skin is not going to heal well. A reconstruction may not work because that skin quality is not going to survive. So you can't always get what you want. If your breasts are empty, you've had a lot of children, they're deflated, there's no tissue in there, they're very soft and fatty, then there isn't good quality tissue for us to move around and give you that shape. So there's lots of things it depends on. But if we aim to save as many breasts as possible, reasons women may want to have a mastectomy instead of a lumpectomy is because they don't want to have radiotherapy, or they physically can't have radiotherapy. Now, most of the time, regardless of wheelchairs and other medical problems, we can get you on a radiotherapy table. But if you don't want it, it's just too much, we can do a mastectomy to hopefully avoid it. A lot of people think having a mastectomy stops your cancer coming back. I want everything done to stop it coming back. And it makes sense, but it's not true. You can have a 1 centimeter breast cancer and a little cell can escape, go through the tissues and end up years and years down the line in your bones or your lungs. It's got nothing to do with the size of the tumor. It's the grade and the type. So a mastectomy does not stop breast cancer coming back. And you can get a local recurrence like I did in the skin or the breast even after a mastectomy. So what we're trying to do is to stop women having mastectomies for the wrong reasons. The paper that was done looked at all the studies to date to see whether having a mastectomy gave you a better or a worse outcome than a lumpectomy. And they were just looking at women with small cancers who could choose to have both operations. Some were just looking at triple negatives. Some were very badly done. Some weren't designed to look at this. They've just fudged the data. And all these studies were very biased. It's not good data. It showed there may be a very, very, very slight increase in your survival if you have a lumpectomy instead of choosing a mastectomy. But the people who wrote the study said this is really low quality evidence. Do not make any clinical decisions based on this. It's just people doing research to see if there's something there, and it's not. So if you had a big cancer and needed a mastectomy, ignore it. If you've got a small cancer, it is your choice. But having a mastectomy will not improve your outcome, will not stop your cancer coming back. And I think that's the key issue to get across there.
Yeah. And I think that leads us on nicely. I mean, 2 points. One, it's about sort of absolutely your own cancer. Really, it's about talking through the features of your cancer, your own body, your own wishes with your treatment team, because they know the best way to manage that. But also, I think everyone's knee jerk, or I often have heard when I was a breast care nurse, when we got diagnosed, take it off, take the other one off too. Yeah. And I think that's another question that comes up so often about the other breast.
And I think you don't think rationally about what your breasts mean to you because they're just breasts. And the minute one has cancer, it's you panic, get rid of them, they're going to kill me. I can't imagine with them, without them. It's really hard to think rationally. So when it comes to the other healthy breast, we know that if you have breast cancer in one side, you are more likely to get a cancer on the other side. Now, that doesn't mean you're going to. It's a very small risk, but you are slightly more likely to get that. However, all the treatment we give you, the radiotherapy, chemotherapy, if you have it, hormone blockers, immunotherapy, Herceptin therapy, greatly reduces the chance of that happening more than a healthy woman in the street. Having your healthy breast removed will not stop your breast cancer coming back. Because as I said, you can get a tiny cancer when a little cell escapes and that can stay floating dormant for 20 years. It has nothing to do with stopping this cancer coming back. And it also won't stop you getting a cancer in this breast. And that's because, talk about local recurrence, it's impossible to remove every breast cell because they are invisible to the naked eye. And I describe it a bit like trying to peel all the pith from an orange segment. You can't. There are women with a BRCA gene where they have an 80% chance of getting breast cancer who have a bilateral mastectomy to stop them getting breast cancer, but about 3% will still get a small cancer in those cells underneath the skin. There are two reasons why we might we might consider it. One is if you are having a reconstruction using your tummy, a DIEP flap, and they're going to throw half the tissue away. But actually, if you've got breast cancer in the future, you'd be very lopsided. So we may sometimes do it then. Sometimes we do it for extreme anxiety when women cannot cope with the thought of it coming back or having another mammogram. But these decisions take time. We take months or even a year to meet psychologists to make sure you're doing it for the right reasons. I also think that symmetry should be a good reason to have the other breast removed. I actually wish I was flat than having one side. But the problem is hospitals often don't get funded to do operations that don't affect your cancer outcome. So you may want it and your surgeon may want it, but they're not allowed to do it. Yeah. But these decisions take time, so you're not rushing into it.
Yeah, and absolutely. It's such a difficult decision. We speak to so many people on the helpline about that. And if anyone did want to speak to anyone around decision making for surgery, our Someone Like Me service, which we'll have a link in the comment, you can speak to people that have had a mastectomy, lumpectomy, reconstruction, no reconstruction, and some sort of, again, sort of symmetrization procedures after on the other side.
There's another operation we do, which is like a mini reconstruction. So if you have a small breast and a big cancer and you don't want a mastectomy, what we can do is take a bit of your fat and we can move this to fill the gap. So you kind of have a scar here and we use this tissue to fill the gap to stop you having a mastectomy. That's being done. I would say when I was diagnosed, I had a big cancer in a small breast. I could not imagine being flat. I wore V-neck dresses. I couldn't imagine wearing a full prosthetic bra and turtlenecks for the rest of my life. And I felt guilty. Vanity was a reason. But when it came back and I had to go flat, actually 5 years later, I'm completely happy. I wish I'd never had the implant. But the decision I made at the time was right for me. And I see so many women making decisions based on what their partners think or what they think they should do. They're not the ones that have to live with this.
Yeah. And again, as you've said, there's no right or wrong decision in all of this. It's such a personal decision. And as you say, again, what's right for the person at the time may not be the right thing a few years down the line.
And that's fine. Things can be changed. You can have things delayed. You can have them come up. There's so much to get your head around. But again, there's someone like me. You've got great information on the Breast Cancer Now website to help you listen and look at scars and think. And a lot of it is actually, how soon do you want your life back? Because a lumpectomy and a simple mastectomy, in and out in a day, back to normal in 1 or 2 weeks. If you have a tummy reconstruction, you're looking at a 6-month recovery with no heavy lifting. And another thing to think is, do you want to look good in your clothes, in your bra, or naked? That can help. And it's not a breast reconstruction because the skin is numb. It's fixed in time and space, whereas your natural breast will head south for winter. It has no sensation, no erogenous zones. It's not a breast. It's a mound of tissue, so you don't need to wear a prosthetic.
Yeah. And I think that's really, really key about managing expectations. Yeah. And I think we'll come back to that about the sort of change in sensation as we move on about sort of talking about that. But I think, I know we'll just briefly touch on sort of the 2 main types of breast reconstruction that there are before moving on to armpit surgery.
Yes. So 2 types of reconstruction. Well, actually, there's so many ways of doing it. You can have it done at the time, which is immediate, or delayed. Delayed generally means a 2, 3, 4 year waiting list because the backlog of COVID, it takes time. So you've got the timing you do it. You can, if you are small breasted, so trying to stretch it. Sorry, Louise, I'm just getting my head around it. Okay. Right. If you are slim like me, and you don't have much of a tummy, and you are right, no, sorry. Okay, this is so complicated to explain and I'm struggling. The 2 options are to have an implant, which is put underneath your breast skin. And what we do is we use a mesh that keeps that implant in like a little hammock or a sling underneath the skin. And the mesh gives the skin a bit of a nice drape. So you don't get that Posh Spice Pamela Anderson effect. The implants are generally put in at the same time as the mastectomy. Sometimes we use expanders, and what they can do is control the volume of the breast whilst you're having radiotherapy. Implants generally need changing every 10 to 15 years. They will stay fixed in place, whereas your other breast will head south for winter. They develop a capsule normally. That's like a pea in a shell. And what can happen over time is that capsule becomes hard. It can cause pain. You can get a tennis ball. It happened to me. It can happen with and without radiotherapy. And some surgeons will not do an implant if they know you need radiotherapy because it can bugger it up, pardon my French. To have an implant, you've really got to be smaller than a D or an E cup, because again, if you've got a really big breast, I can't create that shape with an implant. An implant looks good to about a double D, but after that, it's not going to match the other side if what you're doing is trying to look good naked. You just want to look good in a bra, then we can fix that. But basically, an implant is a smaller breast. And to keep the nipple, you've got to be like a C, D cup pushing it. The other type of reconstruction is using your own skin. The commonest is a deep flap or Dieppe flap, and that uses your tummy fat, basically kind of the pouch, I guess, below between your tummy button and where your pubic hair is. And we take that fat and skin on two connecting blood vessels. The plastic surgeon, and these are done in centres where there are plastic surgeons. So my patients in Ipswich had to go to Chelmsford because I didn't have plastic surgery on site. It's an 8 or a 10-hour operation. They plumb in the new fat and skin into blood vessels coming up through the ribs. If you're keeping your breast skin, then they just keep a little disc of skin where the nipple was. They need to make sure that skin is healthy. If you have this as a delayed procedure, then what they do is they put your tummy skin creates a new breast. So you do have a scar that goes all the way around the outside. And if you were hairy and your pubic hair came up towards your nipple, you may find you get some hairs on your breast, but you can have them lasered off. If you don't have a tummy, there are other options to get breast tissue from. One is using muscle and fat from your inner thigh, either going down the leg or around the crease where a bikini would go. Another is to get it from your bum. Another option is to get it from your back. The final option is with 6 or 7 operations to harvest fat and put that back in, but that can take 7 or 8 goes. Using your own tissue is 2 donor sites, so 2 chances of complications, and it's a 3 to 6 month recovery, and it takes a long time to heal, and it's a long operation. But when you use your own tissue, it feels warm because it's got a blood supply, and it feels and it moves like your normal tissue. An implant is just a cold bag of jelly underneath the skin.
Yeah. And we've had a question come in, Liz, and we've touched on the radiotherapy, but Vanessa's asked, I've got a question, after having reconstruction and radiotherapy, will my breast go back to soft or stay hard?
Is this after a reconstruction?
A reconstruction. It doesn't say what type of reconstruction.
So what radiotherapy does is cause scarring inside the breast tissue, and it often makes it feel a bit like soap. We kind of call it fat necrosis, and it may be hard permanently. Radiotherapy can change the texture of the breast, and it's why it's important to keep examining them afterwards and know what's normal for you. Massage can help. You can firmly massage that breast tissue. You won't do any harm. It may soften up, it may not.
But go back to your treatment team and let them know if it's causing
just let them know there's a new change, and they can just scan and just say, yeah, no, that's fine. It's probably radiotherapy. You don't need to worry, because you're not an expert in this. There is no way of knowing what is going on. So if it feels different, please go back and get it checked out, just to stop you worrying.
And Sam's asked, going back to sort of re-excisions, if you've had a mastectomy after a re-excision, do you try to remove or reuse the lumpectomy scars to minimise the number of scars on the finished result?
So generally, we try to do lumpectomy scars around the nipple. So if you need a mastectomy, we can place that mastectomy scar where we need. So you'd have a scar either around the nipple or a scar below the breast, and we'd use that as part of the mastectomy scar. The problem is sometimes you may have a scar there, and then you realise you need a re-excision, and suddenly it's a bit harder because you can't use that scar for the mastectomy. But we're always trying to think we may need to go back in, so we can incorporate your lumpectomy scar into the mastectomy scar.
Great. And one final question, I think, before we move on to lymph nodes, is Helen's asked, if I've had a therapeutic mammoplasty, and we might need to explain that to people listening, how likely will a surgeon do both breasts to match, considering they would be removing a healthy breast? Would they do it at the same time?
Good question. So a therapeutic mammoplasty is my word for a breast reduction, but it's therapeutic because I'm removing a cancer. Now, nobody wants to be lopsided. and it gets complicated. Ideally, well, there are some surgeons who think we should do both at the same time. So when you wake up, you go from a J. We can't promise the cup size, but just generally we take you down to a CDE. The nipple is raised. We take the breast tissue, and it's an anchor pattern scar. So you have a scar going around the nipple, and then you have like a little T scar. So there's a lot of stitching, a lot of healing. It takes about 4 or 5 hours. Some people think we should do it at the same time when you can get the funding for it. But the problem is when you then have radiotherapy on that side, radiotherapy can shrink your breast and it can fix it in time and place. So what looks symmetrical in a year's time, the healthy side is going to be bigger. Other surgeons say doing it at the same time, there's too many goalposts to match. I'd rather do the cancer side, get the radiotherapy done, let the swelling heal down, and then bring you back. And especially if you need to have urgent chemotherapy or Herceptin therapy, sod's law is you get an infection in the healthy side, and that can delay further treatment. The problem is, in some trusts, if you don't have them done at the same time, there may not be the funding to do the other side because it's not part of cancer treatment, although reconstruction is meant to be given to everybody and things may be changing. But if you do them both at the same time, they may not be symmetrical in a year. That's what I'm trying to say. And it'll depend on your surgeon's preference, and they know what works best in their hands.
Great. Thank you. And I forgot to mention when we were talking about reconstruction, we've just recently updated our breast reconstruction information. So we've got a brand new booklet, which was updated a couple of weeks ago. So we'll put that in the comments as well, so you can have a look at that.
There's a lot of questions to think about. It's you and the healing and your other, who you have to look after. Are you fit enough to have it? There's all sorts. So please take the time to read through it.
And I suppose the other question that comes up so often, I'm digressing, is around pictures. We get so many people that want to see pictures, and I will often say, ask your surgeon to see their work, not just their best results, but a mixture across the board.
So it's quite hard getting pictures of patients. Often we do it on our phones, but there's a load of data protection, having hospital photographers, not everybody wants it. And when a surgeon moves from one trust to another, they can't take all those pictures with them. They're starting again. I worked with a great plastic surgeon at the Marsden who showed women his middle of the road results to see what they thought. And if they think, oh my God, that's amazing, great, they're going to love what I do. But if they go, oh my God, that's awful, you know that expectation is different. This is not the boob jobs you see on Hollywood programs. We are not creating perfect breasts. Your nipples are normally 5 centimeters higher or lower. Nobody is symmetrical. Your breasts are sisters, not twins. But I think if you can see photographs to get an idea of the good or the bad, it really helps you to get your expectations right. And that's why in often support groups, women will show you theirs. It's really worth trying to have a look at photos if you can. And remember, there is always a risk that a reconstruction will fail and you'll end up flat-chested. Yeah. It doesn't happen very often, but it does happen. And this is all, the main aim is to get rid of the cancer, and everything else is a bonus.
Yeah. And the organisation Keeping Abreast has some really good video resources of different reconstructions. Again, just get an idea of what it might look like, where the scars may be placed. So we can put that in the comments as well.
Definitely.
So types of surgery to the armpit. So it's not just breast cancer in the breast that we treat. It's always sort of what do we need to do to the armpit? And there's sort of 2 main types of surgery, isn't there?
Yeah, that's right. So armpit surgery is part of breast surgery. If I was taking a bowel cancer out, I would take the lymph nodes, the bowel drains too. But because these aren't in the breast, they're in the armpit, they are all the same thing. This is not looking for a recurrence. This is just part of the breast tissue. Breast cancers are going to start to spread into the tissues. The first place they'll often go is the lymph nodes. And what I want to do is know, are your lymph nodes involved? Because that helps me plan what treatment you might need. The things have changed a bit because we're giving a lot of chemotherapy first, but we'll forget that. If we can't find lymph nodes and an ultrasound of your lymph nodes looks normal, we can't see anything, then what we do is we test 1 or 2 lymph nodes. And imagine your lymph nodes like a bunch of grapes upside down. I want to find the one at the bottom, which is called the sentinel node. And sentinel means gatekeeper. If that lymph node is normal, we're 99% certain all the other lymph nodes will be normal. So we just want to take that one out. Now, we use various techniques to find this. Sometimes we inject a blue dye at the nipple. We use magnetic beads. We can use a radioactive isotope. And when you are asleep, we make a little cut below the hairline and we follow the dye or the magnets to take out 1, 2, or 3 nodes that get looked at. That's called a sentinel node biopsy. A biopsy means taking a piece. So I'm not the one biopsying the node. It's a pathologist biopsying the node. I'm just giving them the right one to examine. If you have DCIS, a ductal carcinoma in situ, that means your cancer has been caught at an early stage, so the cells can't spread through. You do not get that done unless you are having a mastectomy, because sometimes you can have DCIS involving a quarter or half of the breast. And if there's a large area of DCIS, there's a chance there may be a small area of proper invasive cancer. So if you're having a mastectomy for DCIS, we take a lymph node as well. If we can feel lymph nodes involved, or your ultrasound showed there were involved lymph nodes, and a biopsy confirmed that your lymph nodes are involved, and you're not having chemotherapy first, we will do an axillary node clearance. Now, there are 3 levels of lymph nodes, depending on a big blue vein that scares the life out of me that goes from your heart down your arm. Level 1 and 2 are below it, level 3 are above. We take level 1 and 2, and that's about 10 to 20 nodes. Some people have 30, some have 9. We don't go up here unless you're young and there's a lot of lymph nodes and we really want to remove them, because this is tiger country where there are lots of nerves and veins. So generally you have level 1 and 2, we take them all away. The difference between a biopsy and a clearance is shoulder stiffness. Because it's a bigger operation inside, you're going to get more shoulder stiffness afterwards, and an increased risk of lymphedema. What that means is lymph fluid collecting in your fingertips and your arm and your wrist and moving up. Because I've disconnected the glands the lymph vessels are draining into. They're kind of going, well, where do I go? So the fluid starts collecting. The risk with a sentinel node is about 5 to 10%, and with an axillary clearance, it's about 20 to 30%. Can't predict it. The risk is lifelong. However, new trials in the last couple of years have shown that if your sentinel node biopsy comes back positive, like mine did, normal scan, normal examination, but under the microscope there were cells, you now have the choice of having a clearance to remove the rest of the nodes or radiotherapy to treat them. They both have the same outcome. They both have similar complications, and your team will go through that with you. None of the surgery we do to the armpit is trying to cure you or treat you or stop it coming back. It is purely information gathering to find out what you need. But with new things like oncotype and trials and how we treat them, we almost don't need that information anymore. If you have chemo first, that may kill the cells in the nodes. We had no idea how many were involved in the beginning. So we're relying on it less and less and less.
And I suppose there's that similar question around the re-excision. When you get a positive node, we often have that dilemma from people ringing up saying they've suggested that I either need axillary node clearance or possibly radiotherapy. And what if there's nothing further there and I'm increasing my risk of lymphedema?
So this was me. So there are levels of positivity. You can have isolated tumor cells where there's just a couple of them. You can have a micromet where it's less than 0.2 millimeter, or a macromet where there's more than 0.2 millimeter. And that just shows how much of the lymph node is involved. And if you just have one node at the sentinel biopsy and that's positive, you don't know if that's 1 out of 20 or is that 20 out of 20. Now, we assume the chances are it's going to be 1 out of 20 because your scan was normal, your examination was normal, but we don't know. If there's 3 or 4 sentinel nodes, it makes it much easier where they're involved. I had 2 out of 2. And I wanted to know how many were involved because it's a surgeon in me and I wanted to know the numbers, but I had the operation. There was only 1 more. Now, I'm lucky I haven't had lymphedema, but I've had severe frozen shoulders and stiffness and reduction in mobility, and there are risks to this. And I think you kind of have to trust your surgeon. You may be scared thinking there are some lymph nodes that are involved, but all the treatment you're going to have is going to kill breast cancer cells anywhere in your body. And if the scan has shown there aren't heavy disease in your armpit, then actually it's probably okay to rely on what the surgeon's saying. They may say, actually, we're not going to go back. because we're more likely to cause you harm, then we're more likely to find nodes. And actually, all the drugs we're giving you, the CDK inhibitors, the more people are getting, are going to kill off those cells. So it's a very grey area. And I think you just have to trust your surgeon to guide you. And I know the uncertainty is really, really hard. It's really hard to get your head around. And you'll see different people in different places having different things, but you can't compare you to any other person because it's all treated on an individual basis.
Yeah, thank you, Liz. And I'm just looking here. There's a question that's come in. And I think you've answered that. Samantha asked, hi, when you have an axillary clearance, are all the lymph nodes taken out or only those affected?
So we take out all the lymph nodes we can feel below your axillary vein. If we have to go above the axillary, and I'll only do that, I've only done it twice, in a young woman who had heavily involved lymph nodes right up here, and she was at risk. We're scared of leaving obvious disease behind, because if you get cancer up here, it can stop your arm working. It just interferes with all the nerves and the blood vessels. We used to see it a lot 50 years ago. I haven't seen one in my whole 20 years of practice. But if we can feel little nodes up there, we'll get them, but it can sometimes mean dividing a muscle or going up underneath the collarbone. It's the risk of causing lymphedema is really, 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 really high. And now what we probably do is just zap them with radiotherapy. We take all the nodes we can feel.
Yeah. And I suppose one more question around sort of lymph nodes is that there are lymph nodes elsewhere in the breast, aren't there? So in the centre part of the breast and behind the collarbone.
Yeah.
And they can't be removed often, can they?
No, 90% of the time, the sentinel node, that draining node, is here in your armpit. But I was actually involved in the initial studies back in 1998. They did also remove sentinel nodes here. You have a chain of lymph nodes that come just beneath your breastbone. And in about 10% of cases, it's actually this one. But you would see these on a scan and we don't. And going in between the ribs is dangerous. We don't like doing it. If they're concerned that you may have lymph nodes here, we can treat that area with radiotherapy, which is what I had. If you have positive axillary lymph nodes, then you get radiotherapy to treat the supraclavicular area. So what we do is treat these lymph nodes with radiotherapy to kill any cells that might be there. So that happens automatically if you have positive lymph nodes and go on to have radiotherapy.
Great, thank you. So I think moving now really to some of the sort of what to expect after surgery. And I think while we're on the topic of the armpit is seroma. And what is a seroma? And I think for those that maybe have had a seroma, it can be really frustrating if it lingers on.
Bane of my life. So seroma basically means a collection of serum. So when you cut yourself and you pick the scab and you get that clear fluid underneath the blood clot, that's serum. And the body produces it to fill a hole. It's completely natural. And it's why years ago when we just removed the breast tissue and left a gaping hole, that would fill with fluid. And then as radiotherapy kind of shrank it away, the breast kind of shriveled. It's completely normal. If you've had a lumpectomy, there may be a little bit of fluid in there, but sometimes the body can produce too much. The stress of surgery, the trauma of having things poked around means the body produces fluid and your breast swells. And it can swell 2-3 cup sizes and feel very, very tight and uncomfortable. It can happen with a reconstruction, with an implant reconstruction. There's a space between the implant and the skin, and it's like a little envelope that the body can fill with fluid. When a mastectomy happens, you've got a huge envelope. So you've just got skin lying on the chest wall, and this can all fill with fluid. That's why we often put drains in to kind of reduce any fluid that comes away. And we put drains in the armpit after an axillary clearance to try and drain this fluid off. Some surgeons, and I hate it, quilt. So what they do is they tack the skin down to the muscle underneath, but this can often cause lots of pockets of seroma and it's sore, and I think we're doing that less. So it's a natural thing that when it happens, it's an uncomfortable pain in the bum. The problem is, if I drain it off completely, the skin's still being stretched, the body can go, well, hey, I'll just grow again. In time, the body will absorb it by itself. And that can take weeks. In some places, it can take months, especially if you've had tissue taken from the back or the bum, and it's hard to live with. It's easy to stick a needle in and drain it, and the skin's numb so you don't feel it. But the more times you put a needle in, the greater the risk of infection. And again, if we take it down to nothing, that skin is still stretched. So what we try and do is just leave it unless it's tight and under tension and you're in pain. Sometimes we inject like talcum powder into mastectomy cavities, or just try and score the lining if they're persistent to try and make them stick. There are no easy answers. The drains, just let it slowly trickle away. So hopefully that space will just shrink and shrink and shrink. Skinny people get them, fat people get them. There's no right or wrong. We don't know why. It's just because breast tissue is mainly fatty. There's a lot of fluid that's produced.
Yeah, and I was going to say, I remember when I was a breast care nurse in the early 2000s, having clinics full doing seromas, and actually as the years progressed by, we were sort of much more about them being symptomatic.
Yeah.
So if people were uncomfortable or it was putting excess tension on the scar, then you would. But as you say, I think introducing a needle always runs the possibility of an infection. And I always, and it may not be the case now, but we used to sort of steer people away from going to A&E because sometimes they were sort of managed more like an abscess as opposed to...
Yes, A&E doctors don't know. And often, the first time I did this as a junior doctor, I drained a seroma. It was bluey green. I thought, oh my God, this is infected. I didn't realize it was blue from the blue dye we'd used to find the lymph node. And I was about to give her antibiotics because if you're not a breast surgeon expert, you don't know what to do. And that's why we often say wearing a sports bra or sleeping in a bra for the first 2 or 3 weeks, just that compression on the breast tissue can often stop seromas draining. Seromas forming, sorry.
Yeah. And would you say, I mean, again, usually we say as a guide, it can take up to 6 weeks for them to sort of settle, but some people might be shorter, some people might be longer. Yeah. It really depends.
Yeah, I think so.
The other thing, I suppose, about keeping with the axillary is cording.
Yes.
Which can...
So I didn't really know what this was as a breast surgeon. I knew some patients had it and the breast care nurses did stuff. And then I got it myself after a sentinel node biopsy and then a clearance, and it stopped me getting radiotherapy for 3 months. So what cording is, we think, is fibrosis of the tiny, tiny lymph channels that run from your armpit all the way down your arm. And they can also go down your tummy wall, because I had it going down. And they look like guitar strings. So when you hold your arm out, you kind of see these tight little cords. And you can often feel them going all the way down to your armpit. And what they do is they stop you being able to move your arm because they're tight. The treatment is to get your fingers underneath them and snap them. And oh my God, it's the relief. You hardly hear this ping or this pop. You think, oh my goodness. But not a lot of people know what to do. My breast care nurses just told me, hang your arm over the edge of bed with gravity. And I had to find a physio trained in scar release who knew how to manipulate them because they were really thick. And because with radiotherapy, you have to get your both arms above the head. I couldn't do that because of the cording, which is why the shoulder exercises are really, 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 really important. It can come back and you can get it going down your tummy after a reconstruction. It's not worrying. It's not serious. You can rub it yourself in the shower, often when your hands are moist with kind of shower gel or soap, and just try and get your fingers underneath to snap it. And again, often gravity hanging off the edge of the bed can help. Go talk to your breast care nurses if you do have it, and they should know how to help. It's just a pain in the bum, and I had no idea how frustrating it was.
Yeah, I mean, certainly, again, it might vary from hospital to hospital. I was fortunate when I worked in the NHS, we had a specialist breast physio. So anyone that was struggling, we would refer directly on to the specialist physio for extra exercises. There's also a really good resource. Jen McKenzie, who is a physio herself, she was based in the UK, is now based back in, she's Australian, but she's called the Breast Physio, and she's got her own YouTube channel, and she does really helpful videos around that. And she was just sort of explaining, I watched one recently, but again, we can put the links through for that.
One thing, whilst you're on arm exercise, your shoulder exercises are really, 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 really important. You must do them every day for life, because when I stopped, it was awful. It is fine to lift weights. You start with like a 0.5 kilogram weight with your breast cancer arm, and you can move the shoulder, and that helped me. But to reduce the risk of lymphedema, I got this from Melanie Thomas, Director of Lymph Wales. I want you to jiggle your arms furiously in the air. They've done studies that show that the dye in the channels wakes up. And if you've got breast lymphedema after radiotherapy, bend over topless and give your boob a good jiggle. That wakes up the lymph channels and can stop lymphedema developing.
We did a Facebook Live recently with Melanie Thomas, and she did that.
She's fabulous. I'm going to start speaking Welsh now. Oh, she's just fabulous.
Yeah.
Shake your arms.
And calding can happen not just immediately after surgery, it can happen months down the line,
down the
can't
line,
it?
and it can come back. And often we do our exercises in the beginning, and then we forget, and life goes on, and then you just feel a bit numb and a bit tight. If it happens, go back to doing your exercises again. Often for me, just lifting weights in the gym meant I was actually pushing my arm beyond that range of movement. You think, "Ooh, there's a pop."
Yeah. And I think it is that bit. I know when I was in practice, people would say, I just feel like if I do that or I do that, something is going to snap, but
Yeah.
nothing is going to snap.
Don't be
as such.
scared of it
It's not.
snapping. It's just this tiny fibrosed channel just kind of popping. It doesn't hurt. It's just, the relief when it goes, think, oh, this is amazing. Don't be scared. I promise you.
Yeah. And again, we've got information about that on our website, our post-operative recovery booklet, and our arm exercises information on our website.
In the States, calding is called axillary web syndrome. So you may see it referred as that. It's the same thing.
Yeah. Loss of sensation or altered sensation.
Yes. So 2 places where this can happen. If you're having a clearance or you have quite a large armpit and it's hard to find, there's a little sensory nerve that just crosses through your arm, and all it does is supply sensation to this bit of your upper inner arm. And sometimes we have to cut or stretch this nerve to get to your lymph nodes. And if that happens, you will get an area of numbness here. It may be permanent. Sometimes the nerves will grow in. It may be numb, or you may feel electric shocks or a burning sensation. And that's the nerves just trying to find each other. It often settles down in a couple of months, but it's often quite normal to have a numb patch here. I find it really weird when I'm swimming front crawl. I just can't feel the water underneath. When you have a mastectomy done, your skin is numb because we've disconnected the nerves coming through the breast tissue to the skin. So you can feel pressure, but you can't feel pain. You may not feel hot or cold. When we do surgery around the nipple, you may lose nipple sensation. It may not become erect. It may not be erogenous. And if you have a mammoplasty, a breast reduction, you will lose nipple sensation as well. I didn't realize your breast was numb after a reconstruction, and I'm a surgeon. It was only when I had it, I thought, this is really, really weird. It's like my husband's touching it, but I can't tell. It's really strange. That is permanent. In the States, they are looking into nerve-preserving mastectomies. You need a plastic surgeon to do it. It takes about 4 to 6 hours to do. They're often taking tiny nerves and transplanting them, and I'm not sure all the effort is worth the benefit, but they are starting to look into it. And that's for reconstructions.
Yeah. And anecdotally, I think it's really hard because we will say expect there to be loss of sensation, but we'll get the odd person who will say that they get some sensations, although it won't be exactly the same, but it really varies. But
it depends. Sometimes if you've got quite thick, if you are large and you have quite a lot of padding, then there may be nerves in the fat underneath the skin, not in the breast tissue, that still give that skin that sensation. The thickness that we take depends on the thickness of your fat underneath the skin. And in some women, it's 3 millimeters. In some women, it's 1.5. So you may have nerves, if you have a lot of fat under the skin, that do give you some sensation. Yeah. There's no polite way of talking about this, so I'm sorry if I've offended anybody. But yeah.
And I suppose that the hypersensitivity you talked about, I'll never forget, particularly around that area where people would say in those weeks after surgery, even putting clothing or rubbing something past it was so uncomfortable.
Yeah. It's like little electric shocks and burning. So another thing we should maybe touch on briefly is post-mastectomy pain syndrome. I used to breeze over this in the consent form, then it happened to me, and it happens in about 30% of women who have a mastectomy. And again, it's because we're dividing the nerves, and what you often get is a really painful burning electric shock sensation on your chest wall. And it can be bad enough to stop you wanting to wear a bra. It can make you sweat. It can be really, really sore. If you have this, there are lots of drugs that you can take, painkillers that are often used for epilepsy and other things that work as well. Some sites are giving Botox to help with it. So there are drugs available. If you are really, really sore down your chest wall bit there after a mastectomy, please tell your breast care nurses, don't suffer in silence.
Yeah. And that leads us nicely on to ongoing or lasting pain after surgery. I think we've had a question come in. It's my scar in the lower crease is healed fantastically, but I still have numbness under my left arm and a huge amount of pain. And that we do get queries from people that will have ongoing pain maybe several months after surgery.
Yeah. So the numbness under the arm is permanent. And you should have been told about it beforehand, but there's so much information coming your way, you can forget. That is permanent, I'm afraid. The pain can be due to all sorts of things. Some people just get more pain than others. They don't heal as well. If you have other medical problems like diabetes or smoking or arthritis, that can make you more likely to have pain. Not moving your arm can actually cause pain because the muscles get stiff. And radiotherapy is the gift that keeps giving. And you can get post-radiotherapy pain for several months or even years. I think it's monitor it and just say, well, on the 1st of January, it felt like this. What's it like on the 1st of February? If you've had it for a couple of months and it's not getting any better, go and see your GP. They want to refer you back to the clinic. And it may be nothing, but you need someone to stop that bell ringing in your head. It's almost certainly nothing serious. It's just some people take years to heal from a hysterectomy and others are walking the dog 2 days later. We are all different. We all have different things done inside us. But it is annoying and it takes time to heal, especially if you are having chemotherapy and radiotherapy. It can take 9-18 months to fully heal from everything that you've had done.
And for people where maybe it has continued on for several months, and sometimes that could be over a number of years, there's things that they can do. They could go back to their teams and maybe ask to be referred on.
There are things that can be done to the pain clinic. We have local anaesthetic topical patches that you can put on that I've tried. You can have local anaesthetic blocks, different high-level painkillers. There are lots of things that can be done to treat the pain. I think if you've had it for a couple of months and it's not getting better, ask to be referred back to the team. They can make sure it's nothing to do with the breast cancer coming back, and then they can maybe refer you on to a physiotherapist or a pain expert to see what they can do to help.
Yeah. And just to stress for those that may be listening who are about to have surgery, that's not everyone that needs that. For most people, they will recover normally, but actually there might be some people that do go on to have some lasting problems. But certainly it is about letting your treatment team know and getting the right referrals and the right support.
Definitely. Again, it doesn't happen very often when you've got loads of people watching. There's always going to be someone who's had these complications. So,
yeah. And I think there's probably lots more that we haven't covered, but I'm mindful of time. We've been speaking for nearly an hour, but one of the questions that comes up for people after surgery, and I think it's this, I suppose for anyone who's had a breast cancer diagnosis, the worry about it coming back. And lots of people often ask, how do I check and how do I know? And although at breast cancer now we wouldn't advocate there's one set way, what do people need to look out for when they're sort of looking at their scars or their reconstructed breast or their mastectomy?
So we're talking about a local recurrence, which I've had twice. And I realized I never told my patients to check the breast or what to look out for. You don't see it very often. Breast cancer can come back in your breast chest wall area. It's about 5 to 12% of people. It is more common if you've had triple negative disease, and that's like bad biology. We can't beat that. But it can happen. And that's because we can't remove every breast cell because they're invisible to the naked eye. That's why we do things like radiotherapy. So if you've had a lumpectomy, it can come back in the skin around the scar or as another lump in that breast. And that's why it's still important to check your breasts every couple of months. Your radiotherapy side is going to feel really strange. It's going to feel hard and lumpy and bumpy. So you check it every month so you know what is normal for you. And if you notice any changes and it's still there in a month, you get it checked out. It is almost certainly nothing, but we can't promise you that. If you've had a mastectomy, it can come back. This is a reconstruction or a mastectomy. It can come back in the skin. So for this and a wide local excision, you need to look at the skin kind of from your collarbone all the way down to your rib cage. It often looks like a little red spot or a little ulcer that's not healing. And that's what I had. And there are pictures of mine on my Instagram account, just like a little spot that just appears like a pimple, but it's getting bigger, not smaller. It might be a bit scabby in the middle. That's a local recurrence in the skin. And if you see that, you ring your GP and you say, I think it's come back in my skin. Send me to the clinic. You can also get a rash. So sometimes that's a breast cancer coming back in the skin near where it was excised. But sometimes breast cancer can actually come back in the skin itself. And you can get a rash that can come and cover the whole of the breast like a tight, hot red rash. And that means that's when it has spread. That's stage 4 disease. So it's spread to the skin. And you get tight, angry, painful rash. And that needs to be seen and checked out quickly as well. If you've had a reconstruction, a lot of people say, how do I check beneath the implant? It's about 1 in a million you get cancer coming back underneath the implant, because we strip all the breast tissue down to the covering of your chest muscle. There is nothing left. I have never heard of anyone having a reconstruction behind the implant. If, God forbid, it did happen, you'd see the implant being pushed forward. But you still need to check that skin over the reconstruction. And if you've had a diet reconstruction, so you're going to check the skin around where the nipple was, and you're going to check around the edges of the breast. But it's just that vigilance. Every couple of months, have a check, have a look in the mirror, see if there's anything different.
Yeah. And that could be really hard in that first couple of months, can't it? Because again, things can be changing post-radiotherapy, post-surgery. Along the scar can initially feel very bumpy, and then over time that may change. But it's I would always say as well, don't ever think you're wasting your treatment time, because people worry that they're fit. They're going to think that they're hypochondriacs, that they're ringing. And certainly I never did when people rang me.
You feel you don't want to be that annoying woman that's saying, hi, it's me again, sorry. But as a doctor, I'd rather see you and put your mind. I'm paid to worry, you're not. You've paid the NHS, the taxes are coming, you use this as much as you want. We're paid to worry, you're not. And the minute you're worried, you have to tell your GP, you think your breast cancer's come back. They're the magic words, so they can get you into the breast care nurses if you can't ring them directly. Because that fear of worry at home is horrific, and there's no need.
Yeah. And certainly, just as a quick mention, our moving forward course is for anyone who's come to the end of their treatment within 2 years of treatment for primary breast cancer. And we cover all sorts of, we often get asked those questions on the moving forward course around sort of do I need to look out for? How do I check? And things like that. So have a look at our website, or we'll put a link up as well.
It's really important, because so many women don't realise it can happen, and you need to have that. It may be scary, but I think you need to know, so you can then either put your head in the sand and ignore it, or there'll be something in the back of your mind that'll ring if you do notice something different. But we do all need to know. Yeah.
I'm just going to scour just to see if there's any questions that we haven't answered.
Well, one thing about implants, a lot of women ask, can I go bigger? And not really, because the skin, to go bigger, the skin has to stretch, and that skin is relying on the blood vessels coming in. And if the skin is under tension, it won't heal. So it's very, very rare that you go bigger with an implant. It's not boob job shopping. You stay the size you are.
Yeah. I think somebody's asked this question. I don't know if Michelle's asked, I didn't know about the radiotherapy being an alternative to node clearance. I had 3 out of 5 sentinel nodes positive, and a clearance took a further 10, which were clear. I've had chemo and mastectomy due this month. I think, having listened today, I may not need radiotherapy. Is that right?
So if you've already had radiotherapy to the armpit, I know she had a clearance.
It looks like surgery to the armpit.
If you had a clearance, you won't need surgery to the armpit. They may want to give it to you to the lymph nodes above your collarbone, depending on how many nodes are involved and what the local protocols are, because it's changing all the while. But you have one or the other to the armpit. And it depends on units, access to radiotherapy, and how far you have to travel. It may be the waiting list is too long, so we'll just go on and do surgery and get them done. Again, they're the same outcome at the end of the day.
And I wonder if she's asking whether that cancels out her radiotherapy to chest wall. If that was, I suppose that depends on the size of the tumour as well.
We give radiotherapy. Radiotherapy is given to reduce the local recurrence. And everyone having a lumpectomy gets it to treat the rest of the breast tissue. We give it to a small percentage of women who've had a mastectomy. They are generally younger women with cancers larger than 5 centimetres and positive nodes. And it's what I had. And that's just to mop up any cells left at the back of the breast. And sometimes we can't predict you'll need it until we do the mastectomy and we discover, the tumour's bigger than it was, like with some lobular cancer. So that can come as a surprise that you're not expecting.
Great, thank you. I think we have more or less covered everything, unless there was anything else you can think of, Liz, but it's been an hour. That's gone by so quickly.
I tried to keep the answers shortish to cover most things. I think the resources on the Breast Cancer Now website are fantastic. Just take your time and read them, but make the decision that's right for you. And it's not an emergency. Unless you've got inflammatory breast cancer or which we do need to crack on with chemo, you do have 2, 3, 4, 5 weeks to wait and make a decision.
Yeah, And you can always, as I said before, give us a ring on the helpline, talk to
please
our
do.
brilliant nurses.
Thanks,
Good
everyone.
evening. Thanks, Liz.